Hey guys, and welcome back to my channel. If this is your first time here, I'm Nurse Alyssa, and today we are going to be doing something a little bit different because I have been going through my wound care series and different products, but I keep getting asked the same questions, okay? So whenever somebody comments, most of the time it's, I have this chronic wound, I've had it for months, I can't get it healed. So today we're going to be discussing how to heal those wounds. And sometimes I have to be honest, sometimes there are chronic wounds that will never heal. The reason for that is you have to treat the cause to treat the wound. So if you cannot treat the cause, then the wound will never heal. So we'll go more into that in the next few slides. But first, if you could hit that subscribe button, it would be greatly appreciated as it does help my channel grow and it helps me tremendously. So let's get started. So what I'm going to do, I'm going to go over each individual different type of wound category. So as you can see here on the screen, a pressure injury. So that is a wound category. So I will go, each slide will have a different wound category on it. And I'll just go over what it is and how to treat the cause. Okay. Now with some, if you can't treat the cause, the actual cause, I will put in how to actually treat the wound, okay? Now, with every wound, we're always thinking about moisture balance, making sure that it's just in a nice, moist environment, and that infection is being controlled. But outside those factors, if we're not treating the actual cause, the wound will not heal. So for instance, with pressure injury. So what is a pressure injury? So it's a wound over top of a bony prominence, okay? So normally you have a bone that is sitting and there's pressure. So say on your bum, your tailbone, or your coccyx region, and it's somebody, say they're paralyzed and they're sitting all the time. So there's that constant pressure on that bone. A lot of times we see pressure sores in this area, okay? So it is a deep tissue wound that over time forms into an ulcer, okay? Now sometimes you can have shear damage, so if somebody else is trying to pick up or lift that person, shearing can cause, so you'll have the pressure and then shearing against the tissue, and it makes the wound open and larger. So how do we treat this? Okay, we want to prevent it, really is what we want to do. So having the patient not sit in one position for longer than 2 hours, going to different positions, having, say, a rojo, so that's a redistribution seat, and it helps put the pressure over the whole bum instead of just one spot. They also have, if somebody is confined to a bed, they have the air mattresses. So really how we're treating the cause and preventing is kind of the same thing. So treating the cause, we want to reduce the pressure, redistribute the pressure, or remove the pressure, okay? So if we can, we really want to remove that pressure because it will heal the wound that much faster once we remove the pressure. So having a patient lay, if it's on the bum, lay on either side, put pillows under one side of the bum cheek, and it will redistribute the pressure, okay? And if they're not in a seat that redistributes the pressure, we want to get them in one. But really with pressure injuries, we want to prevent them before they happen because they are super hard to heal once you have them. So it's always prevention, but once we have them, treating the cause of reduce pressure, redistribute, and remove the pressure, okay? So next we have our venous leg ulcers. So what is a venous leg ulcer? It's a lower leg ulcer caused by venous insufficiency. So what does that mean? So in our veins, we have these little valves, okay? So the valves are always touching, okay? But as we get older or We have different medical complications, comorbidities. Sometimes we get leaky veins, so these valves don't close all the way. Okay, so then the fluid isn't moving up the leg properly. So that's what causes the ulcer. When we start having, you can normally notice when somebody has venous insufficiency because their legs will start swelling. The fluid just stays in the leg, um, and it definitely needs to be treated. Once we start noticing swelling, we want to start treating the leg before the ulcer is there. But if we don't catch it or they don't come in soon enough, how do we treat it? Okay, so we need to help that fluid back up the leg. So we need to use compression therapy. Okay, now we can't just put somebody in compression therapy because we need to ensure that their leg can tolerate it. Because not only can somebody have venous insufficiency, they can also have arterial insufficiency, and they can have a mix of the two. So we have to be super cautious because arterial, like you'll see in our next slide, arterial is when the blood can't get to the lower limb properly. So we wouldn't want to be putting on compression, moving the fluid up, because this, in people with arterial disease, it's going to hold the fluid up even more than they're already having issues, which will just cause a huge amount of problems. So we always want to make sure that their legs can tolerate the compression first. How do we do this? We do an ankle brachial pulse index, or an ABPI for short. And then we can make sure that they can tolerate it in the strength of compression that they can tolerate. Okay, so that's how we treat it. I know not all nurses can do the ABPIs. Sometimes you have to be specially trained. Um, it just depends. You want to get the patient that you're seeing with this to someone who can perform the ABPI. Most agencies have wound care specialists who can do that. So arterial leg ulcers. So what are they? It's a lower leg ulcer caused by peripheral vascular disease. So lack of blood to the lower limb. So when their heart isn't pumping properly and it's not getting, well, I shouldn't say that the heart isn't pumping properly because sometimes it can be caused by other factors, plaque, whatnot, but blood is not getting to the lower limbs appropriately. So how do we treat this? We want to refer the patient immediately to a vascular surgeon. Vascular surgeons, they can either do surgery, they can do other things to get that blood flowing. So that's how we treat it. Immediately, we want that referral off to a vascular surgeon to get this taken care of. Next, we have our diabetic foot ulcers. So what is a diabetic foot ulcer? So it is a lower leg wound caused by diabetic neuropathy. So what happens is if somebody has uncontrolled diabetes or diabetes for a long period of time, they get neuropathy. So what does that mean? They can't feel their feet. Okay, so what we want to do is prevention. So prevention is number one for diabetics. It's the key. So what we're going to be teaching diabetics is to check their shoes. I have had patients who have had either rocks in their shoes, a toy in their shoe, a thumbtack in their shoe from the day before that they stepped on. They have to consistently be looking at their shoes, feeling, putting their hand inside their shoes, making sure nothing's in there, shaking it out before they put on their shoes, okay? You want well-fitted shoes that properly fit them, and when they take off their shoes, they're going to look at their shoe once again, and then look at their feet. Take off the socks, look at the feet, make sure there's no reddened areas. Make sure there's no calluses forming because calluses cause ulcers, okay? When you have a callus on your foot, it's hard. It acts just like a rock for diabetic patients. They cannot feel that is creating a really sore spot. So we have to be checking it. I definitely suggest for diabetic patients to be going to a foot care nurse to have toenails done and calluses removed on a monthly basis. So how do we treat diabetic foot ulcers once we have one? So prevention is number one, treating it number two. So we want to reduce the pressure. So whatever was causing it, it could be the shoes, it could be a callus, it could have been a toy. We need to remove whatever pressure was causing that ulcer. So remove that. We might need to go to an offloading device. This can be like specific shoes that you wear. You can get them at medical supply stores. And that's for when you have a really bad sore that's just not healing. We want to, when we're walking, completely remove that pressure. So they have different devices for either the front, the back, just depending on where the ulcer is. So we want any calluses debrided. And then infection management. Infection management is very key to the diabetic foot ulcers because they get infected extremely easy. And we don't want it going to bone because it seems like diabetic foot ulcers go to the bone very easy, and then you're just on antibiotics for such a long period of time, normally 6 weeks or longer, to clear up that bone infection. So just managing it, making sure that there's no infection, and knowing your signs and symptoms of infection, using your NERDs and stonies. I do have a video on NERDs and stonies and how to look for the signs of infection, either if it's just a contained infection that just needs a topical, or a deeper spreading infection, and what we do to treat that, okay? Next, we have our malignant wounds. So our malignant wounds are a cancerous lesions causing loss of epidermis. So what that means is you have a cancer spot, either sometimes it's a spot, sometimes it can be a palliative patient who is dying and their cancer has just kind of taken over, and wherever it comes out, the cancer comes out, it comes out. Sometimes it's away from their actual original cancer and it's just spread. So it's just kind of random sometimes where it happens. But cancer lesions, what happens is it starts eating from the inside out. Okay, so you have that loss of skin tissue because of the cancer. Now, unfortunately, most of the time, these are not treatable. Sometimes they are, sometimes a doctor will do surgery to remove the spot, the cancerous spot, if it's just a spot. But if it's more of a late stage cancer, end of life, it's not treatable. So in the cases where the doctor decides that they are going to do no surgical intervention, we need to treat the odor and drainage. Cancerous lesions can be quite odorous, so we would use products such as charcoal. So there is different charcoal dressings that we can use, and drainage management. So normally they are very high drainage wounds, so we just want to make sure that they are being changed daily, and that we're using some sort of dressing that is going to take away all that drainage, and then also the odor, okay? Next, we have our skin tears and trauma. So this is loss of skin due to some sort of trauma. So sometimes as we get older, our skin does thin, and they just happen to hit their arm off the door and it peels back their skin. So sometimes we can have full tissue loss or partial loss. So what we're initially going to do is we're going to cleanse it, and if there's tissue there, we're going to pull the tissue back over, because it will protect the wound, keep it moist. Sometimes it will later fall off, but sometimes it will just stick back there, okay? So how do we treat this? We're going to first stop any bleeding. If you need to use an alginate dressing, that will help get the bleeding to stop. And then we're just going to use moisture management and infection prevention to treat this. You can't really treat the cause because the cause is it was hit, it's already been removed. Now, if this is something that continuously is happening in a patient or to you, there is skin savers that you can get. And I mean, you can just go on Amazon or online and you can get the derma savers. And it's these sleeves that you wear and it protects your skin from being damaged and getting skin tears. Next, we have burns. So a burn is tissue damage caused by heat. Okay. How to treat, we're really not treating the cause because the cause already happened. Obviously, burns hurt, so the cause is going to be removed immediately. But how do we treat this? It's just through moisture balance and infection prevention because whenever we have either skin tears or burns, we always want to be monitoring very well for infection because they can get infected quite easily. Next is our surgical open or closed wounds. So a surgical open wound is a wound that has been left open on purpose to heal by granulation tissue. So what does that mean is they'll leave it open. So sometimes say they're removing a piece of tissue here. So sometimes they'll just leave it open instead of stitching it. Sometimes it needs to be packed, sometimes it doesn't, just depending. But what we're going to do is heal it from the inside out. So that's what it is when they're cutting it open and leaving it open. Okay. Now a surgical close is a wound that has been closed by either some sort of closing device. So sutures, staples, there's many more other devices of how they close things, but those two for example. So now how do we treat? So a surgical opening that has just been left open, we're going to do moisture management, infection monitoring, or management. So we just want to make sure that the moisture is being managed and the tissue is able to fill in, whether we have to pack it or whatever we're putting on that. That's what we need to do. Moisture management, infection monitoring, and management. Now, surgical close, this is something closed by sutures or some sort of closing device. We just need to use a dry dressing. We don't have to put anything on it, just keep a dry dressing over it until they remove the sutures or staples. So that is all that I have for this video. I hope that it helps you in your daily practice, knowing how to actually care for wounds and what we should be doing, because it is so important. It's not all about the actual product we're using. I mean, we're moisture management and infection. Those are your products that we have. But without treating the root cause of things, wounds are going to take so much longer to heal or possibly not heal at all. So I hope this truly did help you guys. If you haven't done so already, if you could please subscribe, it helps me so much. And I'll catch you in my next video. See you guys.